Welcome back, YouTube. My name is Marcin Wejdowski. I am a neuroscientist with a particular interest in brain tumors, especially glioblastoma, and I am also the second-year medical student. And today I'll be reacting to Grey's Anatomy Season 1, Episode 3. Hopefully you'll like it. We'll be looking at brain death. And remember, we can always learn and have fun. Enjoy.
Whoever said winning wasn't everything? Ooh, I'll take that guy.
You'll have to beat me to him first.
Never held a scalpel.
Heads is mine, tails is yours.
Why do you get to be heads?
Oh, because I have a head, and honey, you are a tail.
Excuse me. How do you manage to make everything dirty? Ha, tails. There are plenty of other cases.
So go get one. I was here first.
I am not backing down, so I can do sutures all day while you're up in the
I'll
OR.
be happy to
This is
suture
a
all day.
surgical case, and you know it.
It's superficial. I mean, it's
What,
cool, but
Garrett?
it's superficial.
So
How do you
what?
know those things didn't rupture his peritoneum?
Because he's
Exactly.
sitting up and he's sitting there talking to
Means
us.
nothing.
Hello. Excuse me, I was wondering if you could take these out and sew me up so I
He's
could
going
go on with my
through. He's going
race.
through.
Well, we can't just pull them out. I mean, we have
So what?
to do some
Oh,
tests.
wicked.
No,
Are you
no, no,
out
no,
of
no,
your
no, no, no,
mind?
no.
It's a superficial wound.
First of all, Gareth is wrong, Meredith is right. Just because a patient is sitting and talking to you doesn't mean they're stable. In penetrating trauma, especially abdominal, and remember there is a lot of space in your abdo, the absence of symptoms is not reassuring. In fact, any objects that pierce the body can actually keep you alive for a while because they can work like a cork. So pull them out too early and you may risk a massive hemorrhage. So in real life, paramedics and surgeons never remove these objects in the field or blindly as Gareth did. The priority is to stabilize the patient first, then take them to theater where removal can be done in a controlled way. So remember, never pull out something that's pierced the body. Simple as that.
Unidentified John Doe, mid-30s pedestrian, hit by a motorist swerving to avoid a bike. GCS 3, pupils fixed and dilated.
Oh my god. So this patient is GCS 3, the lowest passable Glasgow Coma scale. No eye opening, no verbal response, no motor response. 3. So now what does that mean? A GCS of 3 usually points to one of 3 situations. Catastrophic brain injury with preserved brainstem reflexes. So the body can still breathe or gag, but higher brain function is irreversibly gone. Second option, catastrophic brain injury without preserved brainstem reflexes. No reflexes whatsoever, no breathing drive, which is effectively brain death, probably this patient. Or a deep coma, which in some cases is deliberately induced pharmacologically in the intense care units. Doctors sometimes put patients into this state to reduce brain activity and swelling, giving the brain a chance to recover. I remember when I was studying neuroscience, I was doing a literature review, which link you can find in the pinned comment section down below. And I came across research on American football players, and basically these studies showed that repeated head impacts, even without obvious concussions, cause cumulative brain damage. The cumulative force of these hits was strongly linked to chronic traumatic encephalopathy. Encephalopathy simply means a disease or malfunction of the brain. Encephalo meaning brain and pathy meaning disease. So chronic traumatic encephalopathy literally means long-term brain disease caused by repeated trauma. Now, if we look at this patient, he was hit by a motorist swerving to avoid a bike. We don't see his scans, but there is one very important clue that may help explain why he's scoring 3 on the GCS. His pupils are fixed and dilated. Last time, I explained that a single dilated pupil can mean compression of the oculomotor nerve, so the cranial nerve 3. The episode you can find here, which this nerve emerges from the front of the midbrain. For example, if we look at our brain, this is the brain and this is the brainstem. So if we look inside, let's open it. You look inside. From here, the third cranial nerve emerges from here, okay? So, if it emerges from the front of the midbrain, we have a patient when both pupils are fixed and dilated. It usually means massive swelling or bleeding. It's forced brain tissue downwards because this bleeding increased intracranial pressure and crushed both oculomotor nerves at the midbrain. This is called central or transtentorial herniation, often involving both anci of the temporal lobes. Lobes. And I know anci is like a fancy word, but it's not that hard. So we have the frontal lobe, parietal lobe, temporal lobe, and occipital lobe. I know.
Occipital lobe.
The ancus I was talking about. If we open the brain, let's open the brain. This is our brainstem. We're opening the brain. We are removing our brainstem, and this is our temporal lobe over here. Over here, exactly. Oh, see? It's the ancus. The ancus is a small hooked, as you can see, shaped part of the temporal lobe, sitting right next to the brainstem. Because if we look again, it sits next to the brainstem, and brainstem itself is also responsible for vital functions like breathing. So imagine that if it's pushed inwards, it compresses these nerves. That's why, oops, the brain started falling apart. That's why the pupils get big and stop reacting to light. Because you have to remember that the brain itself is obviously located in the skull, and the skull is a closed box. There is no extra space, so whatever grows inside, whether it's swelling due to hemorrhage or it is a tumor, it pushes something else out. In this case, in our patient case, it pushes the brainstem, and as well, it compresses the oculomotor nerve, and thus this patient's pupils are fixed and dilated.
Atropine given for a pulse in the 40s, BP 183/112, pulse ox 98%.
Chest wide and mediastinum.
Oh, so what we are actually seeing here is classic Cushing's triad. Hypertension, hyper means high, tension means pressure, so high pressure. Bradycardia, brady means slow, cardia, heart, so slow heart, and abnormal respirations. The hallmark of raised intracranial pressure. It happens because the brain, as I said, is trapped in a closed box. So as the pressure rises, the body pushes systemic blood pressure higher to keep blood flowing to the brain. Baroreceptors slow the heart. What are baroreceptors? Baroreceptors are special stretch sensors located mainly in the carotid sinus and in the aortic arch. Their job is to constantly monitor blood pressure. So when systemic pressure shoots up, like it does here, to overcome raised intracranial pressure, these receptors detect the stretch in the vessel walls, and they send signals to the brainstem, which responds by activating the parasympathetic system. The parasympathetic system is a major division of autonomic nervous system, which basically digests and is responsible for slowing things down. So it's called digest and rest. And it activates this parasympathetic system through the vagus nerve or the cranial nerve head. The result is reflex bradycardia, so the heart slows down and the brainstem gets disrupted, causing irregular breathing. Atropine, as she said, here only buys time by treating the bradycardia, but it does not touch the real problem, which is the raised intracranial pressure.
Chest shut widened mediastinum and head CT revealed cerebral edema. He's gotten 70 of mannitol, dexamethasone 10, and a gram of phenytoin.
Get him to the OR.
Is he corked?
Looks like.
The bike race claims his first victim. I'll make my AAA repair after all.
Dr.
Okay, so Izzy said widened mediastinum, that can suggest possible trauma to the aorta. So this patient, we know that was hit by a vehicle, so we should actually really think of him as a polytrauma case. Poly means a lot, trauma means trauma. So yeah, many traumas to the body. And also Izzy confirms that the patient's got cerebral edema. Edema simply means a build-up of fluid, in this case blood, I believe, and swelling inside the skull, because as I said, there is not that much space in the skull, so whatever grows here, or if there is any hemorrhage, it increases the intracranial pressure and it must take space of something else. So that pressure actually is what's pushing brain tissue downwards, as I had mentioned, against the brainstem, causing the catastrophic signs that we're actually seeing. So patient is in a deep coma caused by catastrophic brain injury. Next, Izzy said that mannitol was given. Mannitol is an osmotic diuretic, so it works using the principle of osmosis. So water always moves towards where there's more dissolved stuff, like salt or sugar, to even things out. So you can think of it like sprinkling salt on a cucumber. So after a while, after sprinkling the salt on the cucumber, water leaks out and the cucumber shrivels. So when we give mannitol into the bloodstream, it makes the blood more concentrated than the fluid around the brain cells. That extracellular fluid, so the invisible thin layer of water surrounding every brain cell, because when you look at the brain, it looks like a one big solid cluster of cells. But if you keep zooming in, and when you start seeing simple single neurons, you also see surrounding layer, and the surrounding layer outside neurons is called the extracellular fluid. And then the kidneys, because the blood going through kidneys, filter it out as a urine. That's how mannitol reduces swelling and lowers this intracranial pressure. Dexamethasone, because she also mentioned dexamethasone, is a corticosteroid. A corticosteroid is basically a copy of hormones your body already makes in the adrenal glands, and these hormones control inflammation. In the brain, that means less swelling. It used to be widely used in traumatic brain injury, but research hasn't shown a clear benefit there. And a recent meta-analysis has shown that in patients after traumatic brain injury, it actually may increase the chance of death. It's still used to reduce swelling when someone has got brain tumor. The last thing she said, it was phenytoin. It is an anticonvulsant drug. So its role here in this patient will be to prevent seizures after a head injury. It's called post-traumatic seizures. So what it does, it just basically calms down overreactive electrical activity in neurons. So it lowers the risk of another dangerous event on top of this trauma.
Get him to the OR.
Is he corked?
Looks like.
The bike race claims his first victim. I'll make my AAA repair after all.
Dr. Shepard, he's not going to the OR?
No. Do an EEG and confirmatory tests. If he doesn't respond, 6 hours. Declare it.
Declare him. Declare him what?
Brain dead.
Okay, so here McDreamy tells Izzy and Christina to perform brain death tests, including an EEG, and then call it. Here in the UK, brain death is defined as the irreversible loss of all brain and brainstem function. As I mentioned, the brainstem, which is part of the brain, controls breathing, heart rate, etc. So the diagnosis is purely clinical, based on brainstem reflex tests and the apnea test.
Apnea
just means not breathing. This test checks if the patient can take a breath of their own when the ventilator is briefly stopped. Basically, the apnea test is a way to see if the brainstem can still make you breathe when CO2 builds up, because you can control the way you breathe. You can start breathing very fast. You can reduce. You can slow down your breathing. So now imagine that you're just diving. So when you're diving, you have to hold your breath, and once you start holding your breath, the CO2 builds up, and the CO2 built up is being detected by the brainstem. And there is always some range. Some people can hold breath longer, some people not. But the point is, there's always some range. And if you exceed the maximum range of building up CO2 in your blood, you are forced to take a breath, regardless of whether you can't anymore hold the breath. So that's the point. So you're building up CO2, and it actually forces you, your system forces you to take a breath. If nothing happens, that actually confirms brain death. Although I know that there is one definition of death, quite obvious, but there are actually 3 diagnostic criteria: somatic criteria, circulatory criteria, so the most common one, and the neurological criteria that we can see here. In regards to EEG, which actually stands for electroencephalogram, I'm not actually sure why would they use EEG, because EEG actually measures the electrical activity in the brain cortex, so the surface layer. Brain death, though, is defined by the loss of brainstem function, not just cortical silence. Here in the UK, they don't use EEG as a confirmatory test. So I see the point why they can use it. For example, if there is some dispute in organ transplant, for example, or if you really want to show that the patient is dead, you can use EEG as like an extra tool, but not as a confirmatory tool in the UK. Maybe there's something else in some other guidelines in different countries, but not in the UK. And there you go, you reached the end. So if you like it as I like it, you can like it. If you dislike it, that I don't dislike, you can dislike. But anyway, hopefully you had some fun, you learned something new, as I did, and see you next time.